Hello and welcome to this short video on how to communicate with families. This is part of the Pediatric Palliative Care workshop. My name is Dr. Kathryn. I'm a palliative care specialist. At the end of this video, you will be able to outline the components of good communication, to apply active listening skills to improve communication with families, and to apply the Spikes model to deliver bad news to parents. So why is communication so important? Communication is very important in all of healthcare, but it's particularly important when caring for patients with palliative care needs and for patients approaching end of life. We know that good communication with families reduces their uncertainty and anxiety. Good communication also helps to build trust between the healthcare provider and the family. It helps to ensure a collaborative process of care and an involvement of the family in the decision-making process. Good communication allows us to explore the concerns of the family, which may be expressed verbally or implied through body language or reactions. And we also know from research that good communication with families improves a family's satisfaction with the medical care. The consequences of poor communication may be that the family loses confidence and trust in the medical team. It may result in families not revealing information which is important for doctors and nurses to make decisions. It may lead to significant distress for the patient and their family. And poor communication can result in families seeking ineffective care. So for palliative care patients, this may be that families seek expensive treatments which actually will not have any benefit for that child. So we know from research what is most important for families when they communicate with their healthcare providers. Families want to be provided with adequate information, and they want this information to be clear and understandable. Families want their healthcare providers to be honest and to respond with empathy. By empathy, we mean the ability to sense other people's emotions and also the ability to imagine what someone else might be thinking or feeling in their situation. Families want healthcare providers to respond to their concerns and also to attend to their emotions. Families want healthcare providers to discuss what can be done and also which realistic goals they can have for the future. And families want to be included in decision making. So how can we be a good communicator? So we'll discuss a few key points that are necessary for good communication here, and then we'll discuss a couple of skills that we can learn to improve our communication. The good news is that there is evidence to suggest that effective empathic communication probably does not take any more time than communication which ignores the emotional responses of family. So we can be time efficient and be good communicators. So we need to have all of the medical facts ready when we go to speak to a family. If we don't have an answer to a question, that's okay. We can share this with a family and find out and go back to them. Sometimes there may not be an answer to their question, or we may not have the answer that they're looking for. And it's okay for us to share this with the family. It's okay sometimes not to know. We need to be clear about the purpose of the discussion. We need to be both sincere and empathic. And we must speak in a language which is plain and clear for the family to understand and avoiding complex medical terms. And we ought to be alert not just to what the families say, but also what they don't say. So how they respond with their body language, with their tone of voice, with their emotional response, eye contact. So try to open yourself up to receive and observe how the family are responding to your conversation. So listening is really key to good communication in palliative care. We say listening, but there's a term called active listening, which we'll explain in a bit more detail in a moment. Listening allows you to get more information from a family, but it also makes the family feel valued. Allowing a person, a family, to voice their questions and fears can be very therapeutic and can help them to feel less isolated. So when we communicate with families, we should allow the other person to speak and encourage them to speak, and only interrupt if there's really a need to do so. We should listen carefully for hidden questions as a family speak. They may not be clearly asked as a question, but they may be implied while the person shares their story. We should allow periods of silence, and we should get comfortable with silence if we're not used to using it in communication. Silence is important because it gives the person time to think about what they want to say next and provides a space for them to experience their feelings. Often a person will pause before they share something important or painful. So by active listening, we mean we need to show the family that we are listening to them. And what we mean by that is we will nod our head on occasion, or we will actively say mm-hmm or yes or whatever is appropriate in your language to encourage the family to continue. We should also have an open, what we call open body language. So we should sit at the same level as the family, or if we're talking to a patient, we should crouch down by the bedside and avoid standing over somebody. We should maintain eye contact. Our facial expression should be appropriate for the discussion. And we should have an open posture, meaning that we should not cross our arms or be closed. We can check our understanding of what a family have shared by summarizing what we have understood after they've finished talking. And this is important because it shows a family you've listened. It means you know that you've got the information correctly. And we must absolutely avoid making assumptions, so filling in our own gaps. So now we're going to have a look at how to break bad news to a family. So what do we mean by bad news? Well, bad news is any information which alters either a patient's or family's view of their future for the worse. Delivering bad news may be required at different stages of a child's illness. We may have to break bad news at the time of diagnosis, at a time when a treatment is no longer effective, and also when sharing a poor prognosis with the family. The larger the gap between the family's expectation of the situation and the medical reality of the situation, the worse the news will be for the family. So when breaking bad news, being open and honest are absolutely key. We should aim to speak to both parents together if possible. We should allow as much time as is needed to have the conversation. We should involve the family in any decision making that needs to be done. And we should acknowledge the family as experts in the care of their own child. Bad news, breaking bad news is a very important skill to get right. And the reason for this is that the way bad news is delivered to families can have a significant impact on the family's satisfaction with the discussion, on their understanding of the information. But more importantly, it can have an impact on the family's satisfaction with medical care as a whole, as well as their level of hopefulness and their psychological adjustment to the serious illness. So we can use the SPIKES acronym as a reminder for how to break bad news, of the different steps involved in breaking bad news. So S stands for setting, P perception, I invitation, K knowledge, E emotion, S summary. Delivering bad news is a complex communication task. In addition to the verbal component of conveying the bad news, it also requires other skills, including how to respond to the parents' emotional reactions to the news. So if we look first at setting, to deliver bad news, we need to first arrange a quiet and private space wherever possible. Make sure there will be no interruptions, which means turning off your mobile phone, or if you can't turn it off, give it to a colleague for the duration of the consultation. Make sure you've reviewed the notes and that you have all the information you need to speak to the family. Involve others in the discussion. So if both parents aren't around or aren't available, maybe invite another family member to provide support to the one parent present. You can also think about inviting in another member of the healthcare team, a nurse, another doctor, one of the mental health team. Make sure that everybody is sitting down and start by introducing everyone. Allow enough time for this encounter. P stands for perception. So we need to check first how much the family know about the child's condition. And we must always get this information from the family before you give any information. So we can do this by simply asking, let's imagine our child is called Ahmed. What have the doctors told you about Ahmed's condition? Or, what is your understanding of why Ahmed is sick? I stands for invitation, and this is asking permission from the family to give more information. So, for example, can I tell you more about what is happening to Ahmed? Now, this information ought to be delivered by doctors, so doctors really should be the one to break bad news to families. Other members of the healthcare team can then have follow-up discussions and go over and make sure they clarify the information that's been given, but it's key that the doctor is the one who actually gives this information to the family. So the K of SPIKE stands for knowledge. So prepare well in advance and make sure you have all the facts before the meeting, as we said earlier. We need to warn the family before giving any bad news. And this can simply be by saying, I have bad news. Provide information in a stepwise manner so that the gap between the family's expectation and the medical reality can be narrowed gradually. Share information in small chunks at the pace of the person you are communicating with. And check frequently for understanding. Use simple words that can be easily understood, but also tell the family, sometimes I use words that not everyone understands. Please stop me if you don't understand. It's worth remembering that delivering bad news does not have to be done in one session, and it is often best done in stages. So it might be delivered over 1, 2, 3 conversations with the family. Avoid giving any information that is not true. So E stands for empathy and emotion. So we need to listen to any expressed worries or fears. And remember that denial can be a way of coping with difficult news. Encourage the family to share how they are feeling. And stop talking if the family shares very strong emotions, which may be anger or it may be crying. And allow the family to express these emotions. A useful phrase which can show families that you are connected with their emotional response is simply to say, I wish the situation was different. So there are different empathic responses that we can use to respond to a family's emotion. And to remember them, we can use something called the NERS model. So N stands for name the emotion. I can see that you are feeling very angry. And often when we do this, it allows the family to relax, and usually the anger or the sadness gets less. And the reason for that is the family realize that they've effectively communicated their emotion because you've named it. I recognize that you're feeling very angry. U stands for understand. An example of this would be, I expect most people would feel that way in your situation. R stands for respect. An example is, you have shown remarkable courage during this illness. S stands for support. For example, we will support you through this. And E stands for explore. Tell me more about how you are feeling. And the idea is you will choose one emotional response, one or two, empathic responses to respond to the emotion, depending on the situation. So you'll see which one feels appropriate. And the S of spikes, the final letter, is summary and strategy. So we should check if the family have any other questions or would like to go over any of the information again. We should review the plan for the next steps and offer a follow-up discussion. And we should always document the discussion we've had with the family in the file so that others will know what's been discussed. And finally, a couple of additional communication tips. When communicating a prognosis, an estimated prognosis to a family, avoid giving numbers. The reason for this is that we know that the family hold on to that number and will count down, whether it's 6 days or 6 weeks or whatever number you give them, and families find it very unhelpful. We don't know the number of days or the number of weeks, we just have a rough idea. So instead give an estimate. And this can be, for example, hours to a small number of days, or days to a small number of weeks, or weeks to a small number of months, depending on the child's situation. Avoid the phrase, there is nothing more that we can do. There is always something more we can do, even for children in the very last hours of life. So instead of using this phrase, try instead, although there is no cure for this illness, we will continue to support you and your child and manage your child's pain and any other symptoms. So in summary, good communication is absolutely essential to providing palliative care for children and for children and families approaching end of life. Communication skills can be learned. Communication skills include active listening, using silence, and also responding empathically to families' emotional responses. And the acronym SPIKES is a useful reminder of the steps that need to be taken to help us break bad news to families effectively. Thank you for listening.